So we will wait a little bit until the most attendees can join us. So, okay. I think I will start to open this webinar, Lunch and Learn webinar. And I would like to welcome you all very warmly, all participants from all over the world, and especially our speaker, Professor Christina Schwenck. And I hope you can all hear and see me. And yes, this is me. I'm from Switzerland, director of the Department for Child and Adolescent Psychiatry. And most important is Christina Schwenck. And it's a pleasure for me that I can introduce you to Christina and Christina to you. And she is professor for clinical child and adolescent psychology at the University of Gießen in Germany. She studied psychology at the universities of Würzburg and Madrid in Spain and completed her PhD in developmental psychology at the University of Würzburg. She worked then in different departments in Germany at university hospitals, Würzburg, Munich, and Frankfurt. And she has also conducted her training in PCIT for selective mutism with Professor Kort in New York. She's a trained child and adolescent psychotherapist with a specification in behavior therapy and a trained supervisor. Her research interests include selective mutism, but also conduct disorders in children of parents with mental illnesses. In her free time, she likes very much to do photographies around the globe. But Christina is also very much involved into the IACAPAP. Between 2018 and 2022, she was Secretary General, and she's now at the executive as a coordinator of the Helmut Remschmidt Research Seminar, very much involved. Her vision is to strengthen the training and promotion of child and adolescent mental health professionals and also of the allied professions. So I think today you will present your work for us in selective mutism, and we are very happy to hear you. Before I give over to you, Christina, and give you the floor, I want to mention that we have after the talk of 30 minutes time for question and answers. You can also use the chat box and write down your questions, but you have also free time at the end of the meeting. And if you want to have a certification, please stay until the end, and you can have then an e-certification. So now I will give over to you, Christina. I give you the floor and stop my presentation.
Thank you very much, Susanne, for the kind introduction. I will start right away with a presentation because, as always, I have lots of slides and I would like to present this topic, which is highly important to me and to you, and give you some insights into selective mutism, a challenge for various mental health professionals. So first of all, I want to state my conflicts of interest. I have a fund from the German Research Foundation on a program which is on freezing as an underlying mechanism of silence in children with selective mutism. Except from that, I don't have any conflicts of interest. So first of all, I would like to start with the symptomatology of selective mutism according to DSM-5 and also to the new ICD-11. Selective mutism consists of a consistent failure to speak in specific social situations in which there is an expectation for speaking. Here it's very important that it's a consistent failure. It's not random, like sometimes kids speak, sometimes not, but it's consistent at very specific social situations. So typically these children speak without any problems with their parents, in the closer family, but they have difficulties in speaking in public, or for instance, at school or at the kindergarten. They have unimpaired speaking behaviors in other situations. So these kids can speak in general. And there must be an interference with educational achievement or social communication, which is easy to imagine that these problems occur very rapidly and also to a certain extent. The duration must be at least 1 month, and it should not be the first month of after school entry, because this is very stressful for all kind of kids. And it must not be attributable to a lack of knowledge or comfort with the spoken language or any other disorder. So very importantly, selective mutism is an anxiety disorder. It's not a conduct disorder. It's not that these kids want to provoke somebody, that they do not speak in certain situations, to cause some difficulties. They are anxious and they have an anxiety disorder. They cannot speak. And this is very important. The next thing is we have a prevalence of about 1%, and I would say this is a conservative estimation. So probably we have even more kids with selective mutism. We see a very rapid chronification and generalization. And this is due to the fact that if you imagine how many times we speak with others, or how many times a kid speaks at school or at the kindergarten, not only during the lessons, but also during the break or something. And if you count all these times that these kids with selective mutism miss the chance to speak, to tell their opinion or something, then you can easily imagine how rapidly this kind of behavior shapes and gets a chronic incident. So except from these, or let me go back. So what we see here, that is, we don't have many symptoms specified in the DSM-5 or ICD-11, except from the core symptom, the consistent failure to speak. So we did some research to identify other or additional symptoms beyond that, and also the content of the fear. So what is it that the kids with selective mutism are afraid of? Because this would give us some insight into targets for treatment. And to learn about that, we conducted some qualitative studies, and we're asking parents and children and adolescents with selective mutism themselves about the fear content. So what are you afraid of in the situations that you cannot speak? Or which other symptoms do you notice in situations where your kid is not speaking? So what we realized is that many kids and many parents stated symptoms that belong to social anxiety. So these kids are afraid of being watched at, being maybe negatively evaluated, of making mistakes. All kind of these symptoms are typical for social anxiety disorder. We also noticed that many of them reported some freezing behavior, and I will come back to that in a minute. Then many stated that they would show avoidance behavior, or would avoid a certain situation or feeling by remaining silent. and that they would also show safety behaviors. So these were the most important additional symptoms and fear contents. And except from that, we also had some others, not so frequently, but sometimes mentioning low self-esteem and a negative effect in general. Some mentioned oppositional behaviors, especially in the home situation, and the fear of making mistakes. So let me go back to the freeze response, because this is something that might not be known by everybody. So what is freezing? If we imagine a typically developing kid without selective mutism, and this little sweet dinosaur, like a very small kind of threat, which is not actually too much, nothing much will happen with this typically developing kid. So if you would assess heart rate, for example, or skin conductance as an assessment of arousal, we would not see much. If this kid would be confronted with this big and dangerous dinosaur, of course, we would see some arousal, and the kid would probably react with some fight or flight response that we all know. So if you would have a kid with selective mutism or with a large behavioral inhibition, which is a personality trait that is linked to anxiety disorders in general, and especially to social anxiety disorder and selective mutism, already this small little dinosaur would probably cause some arousal to an extent where a flight or fight reaction would appear. But if the big dinosaur would come, it would come to a third reaction, which is freezing. So nothing much can happen anymore. The kid, does not move anymore, and this also causes mute behavior. And this might be an underlying mechanism of selective mutism, or of one of the reasons the kids cannot speak in certain situations, because they experience these situations as a huge threat, which is not a threat for typically developing children. So there are more factors that are associated with silence, and this also relies on a qualitative study. So we asked parents which characteristics of a person, a place, and an activity elicit failure to speak in your child. And to know these characteristics is also of high importance with respect to treatment targets. So with respect to person, many parents answer this question with respect to characteristic of lack of distance. And lack of distance, what is meant by that, 45% of the parents mentioned this, is people that put pressure on the kid, that are very demanding to the kid, that somehow come too close and to the kid, and get there with their demands. Then authority characteristics, and this includes, for example, medical doctors, also psychologists, but also teachers, for example. Low familiarity. Then we had some external characteristics which were totally random. Some parents said, okay, it's men, it's women, it's old people, young people, whatever. And then 22% said that it's people that are very little child focused, like not very empathetic, not very much being interested in the child, and so on. With respect to the place, the vast majority of the parents said it's unknown places that the kid doesn't know, that it does not have any experience with. Interestingly, 44% answered with crowds. So this is also a situation where kids can be overheard, but we also know that kids with selective mutism throughout adolescence develop agoraphobia to a higher extent compared to kids with social anxiety disorder. So this might also be linked. Places with negative experience, and 13% said places with high volume. And with respect to activity, also about half of the parents said it's new activities that elicit silence, motor activities. And here we know that many of our patients cannot swim, do not know how to ride a bicycle, and so on. Activities associated with failure, where they are in the focus of attention, or activities with speech demands. And yeah, this is only 19%. I think this was too obvious for so many parents that they did not even mention it. So we need to keep in mind these characteristics when we do treatment with a kid. And also keep in mind that, of course, there is an interaction between person, place, and activity. That means that, for instance, a kid might be able to speak without any problem with the mother at home, where there is no other people, but on the playground, where it can be overheard and overseen by other kids, there might be silence and the kid cannot speak with the mother even more. So next, the diagnostics of selective mutism. In general, it's not too difficult if we rely on the diagnostic criteria, but we also have some questionnaires that we can use. So internationally, the selective mutism questionnaire and the school speech questionnaire are those that probably are most known and most used, especially in the United States. A downside of these questionnaires is that they do not have norms of cutoff values, but they have means and standard deviations with which we can compare a certain result from a kid with selective mutism. And there's also the Frankfurt scale of selective mutism from my dear colleague Angelika Gensthaler. This questionnaire is available for 3 different age groups: children before school entry, between 3 and 7, children or early school children between 6 and 11, and adolescents between 12 and 18. And here we have cutoff values according to an ROC analysis, and the questionnaire is available in German, English, Norwegian, Suomi, and Hebrew so far, but we have more translations going on. And you can use it for free for research and the clinics, and download it from our homepage if you want to. So which kind of comorbidities we have? The majority of kids with selective mutism does also show the full diagnostic criteria of other anxiety disorders. And here we have to mention especially social anxiety disorder. That means that 2/3 of the kids with selective mutism also have the full diagnosis of a social anxiety disorder. So in the scientific community, there's a discussion going on whether selective mutism is an extreme form of social anxiety, or whether it's 2 distinct disorders with a large overlap. To be honest, we conducted quite a lot of research on that, and still I can't tell you. So the results are diverse, and we don't know. We have also comorbidities with agoraphobia and separation anxiety disorder, elimination disorders and language development disorders, oppositional behavior, not to the dimension of conduct disorder, but maybe oppositional defiant disorder. But we have to be aware that this does not only occur if the kid is confronted with some speech demands, because then the behavior would be anxiety driven. But if we really would diagnose oppositional defiant disorder, it should go beyond these kind of situations. And then there's a discussion going on whether pervasive developmental disorders are also of higher comorbidity with selective mutism. And this is a discussion which makes me kind of unhappy because there are some discussions going on which assume a very, very large comorbidity rate. To my opinion, of course, there can be a comorbidity. This is not the question, but the question is how huge this comorbidity rate is. And we are currently conducting a study at Gießen University to get some more insights into that. I cannot really show you all the results because it's an ongoing study, but I want to give you some thoughts on my thinking about that. So if you have the clinical setting, and as I said before, we all as professionals are kind of authority person and unknown persons, which is something that these kids typically react to with not speaking, but also with other symptoms. Then we would see here also from a kid with selective mutism, limitation in eye contact, reaction to name, nonverbal communication, mimicry, affective expression, and communication in general, which is symptoms of autism spectrum disorder. We would not so much expect these kids to show repetitive behaviors or stereotypes. But the difference actually should not occur in the clinical setting, but they should occur at home, in the home setting. And here we would not expect a kid with selective mutism to show these autism typical symptoms. So if we want to assess whether a kid with selective mutism also has autism spectrum disorder, we should not so much focus on the clinical setting, but more on the home setting, like assessing home videos, asking the parents about symptomatology at home. So the typical gold standard to assess ASD would not really help in the clinical setting, like conducting the ADOS, for example, because it would definitely show some symptoms of autism spectrum disorder also in kids with SM. If you have any patients, we would be more than pleased if you could share this link here. We have an online part of the study, which is international, and everybody can take part on that. And we ask questions about typical symptoms for ASD in different social settings, so to compare whether it is really typical for kids with SM. The second part takes part in our lab, so this is only for people coming from Germany and around the area of Gießen. So some preliminary results on the online study, the first part. So far we have 28 kids with ASD, and here you can see that they show the typical symptoms in both situations, in unfamiliar situations, but as well also in familiar situations. The typically developing kids, which are 70 so far, do show these kind of symptoms to a much lower extent, but likewise. But here in the kids with SM, which are 68 so far, we see a difference between the situations, between familiar and unfamiliar situations. And here you can see this gap, and this is exactly what I tried to explain before. So now I would like to come to the treatment of selective mutism, which probably most of you are interested in. So as a researcher, I'm very much interested in evidence-based approaches. And I also feel that we need to be responsible about our treatments and try to do something that most probably helps the kid with the disorder. And here, this disorder in general is highly understudied, underdiagnosed and untreated, and this also results in little research about treatment approaches. So the few stuff we have so far is on traditional CBT, which contains exposure, contingency management, shaping, prompting, and fading. And mostly we see medium effect sizes here. So this definitely helps, yeah. Then we have the parent-child interaction therapy for selective mutism, which was created by Stephen Kurtz from New York City. And it is a variation of the typical PCIT, which some of you might know. So we also have the first, the child-directed interaction part, but then we have a second part, which is the verbal-directed interaction. So throughout the second part, the kids gets help with brave speaking from adults. And here you can see that we have large effect size on this. We have some few studies on pharmacotherapy, which show an improvement with SSRI, especially older kids with a chronic disorder, or where other treatments have not helped so far. So this might be a good asset to the psychotherapy or to the other treatment. In general, we need to take into account that we have methodological flaws like lack of RCT studies, lack of double-blind studies, and small sample sizes so far. So if we get back to the mechanism of silence, if it was an avoidance behavior, then we would have this typical cycle, like there's a speech demand and the kid has anxiety, it remains silent. Then an adult comes and rescues the kid, like for example, it speaks for the kid, or does something for the kid, or other kids say, oh, you don't have to talk to him because he cannot speak or something. There's a relief in everybody, but no practice for the kid. And when the next speech demand comes, there will definitely be anxiety as well, or even more anxiety. If it's a freeze response, then we have this situation that if there's a threat, like a social situation, the kid remains silent because it cannot speak, because it has a freeze response and an over-arousal in this situation. So what would be the treatment approaches for either of these reactions? When it comes to avoidance, we know that exposure and reinforcement is a good treatment response. If it comes to freezing, then we should make sure to warm up the kid, not to make any demands, and also respecting the stretch zone, which is like, if you imagine there is a comfort zone where it's not difficult for the kid to speak. This is not what we look at, because there is no problem. And then we have a red zone where there's this over arousal. Then we want to stay in the middle, like in the stretch zone, which is difficult, but where it's still possible for the kid to speak. And maybe some slight motor activation might help against that freezing as well. So how does PCI-TSM account for these two kind of strategies? PCI-TSM, as I said, consists of two parts. The first part is the child-directed interaction, where we do not have any speech demands. We do not put pressure on the kid. We just follow the kid's lead, and we do a lot of label praise, like saying what the kid does well, of behavioral description and of verbal reflection and imitation of what the kid does. So it is playing with the kid in general, and then using these four kind of strategies, and also teaching them to parents and to other caregivers like teachers or kindergarten teachers, so that everybody around that kid in all kind of situations does the same when it comes to a freeze response or a difficult situation. And my assumption is that this reduces freezing in the kid in general, so that it's sooner or later possible, after doing that for a while, to start with the second part, and that is the verbal directed interaction. And here we ask questions then, but in a certain kind of way. So what we would prefer is to ask first choice questions, like, do you want a piece of cake or do you want an apple? Yeah, and do you want the red pen or the blue pen? So this makes it much easier for kids to answer compared to an open-ended question, which of course after a while we also conduct. And what might be difficult is a yes/no question, because then the kid can answer with nodding or shaking head, and that's not what we want. we ask a question, then we wait 5 seconds because these kids have a long time until they respond in general. If the kid answers, we make a label praise, like for example, thank you so much for telling me that you want a piece of cake and not a piece of apple. And this, of course, is exposure. Yeah? So some general advice: be aware of avoidance. Don't mind read. This is something that the whole surrounding of a kid with SM typically does. So like if the kid does not answer verbally, but with shaking the head, for example, then we would say, you shake your head. Does that mean yes or no? Like we would insist on a verbal answer. We would not follow any non-verbal communication. If the child doesn't answer, as I said, we would wait 5 seconds, rephrase our question. Then we can do some other strategies, like for example, having the child tell to the parents in the ear what it wants to say, and the parent would say it aloud. Or if this does not work, we would leave the room, for example, and let the child tell the parent, and then we come back, the parent says the answer loud. But it's most important that the kid speaks also in our room, and we do not have a contamination of our room as rooms where the kid remains silent as well. As I said, we have this cascade of question difficulty, like open-ended questions are more difficult than forced choice questions, but also about the content that is spoken about. So it's much easier to speak about facts compared to opinions, for example, or about feelings. So we would not ask at the first glance about what is your opinion on the politics in the United States or something like that, but we would more ask questions like, what is, which day of the week is it today, like a fact. Yeah, also be aware of these typical phrases, which are seem to be easy, but are very, very difficult for these kids, like typical phrases like thank you, you're welcome, hello, goodbye. If I greet a kid with selective mutism in my ambulance, I never say something like hello, yeah, because this is also a speech demand for the kid to answer with hello. But I say something like, I'm Ms. Schwenck and I'm happy that you're here. Very important for the treatment of selective mutism is cooperation. Why? Because we have this rapid chronification and generalization of the disorder, and it's a very underdiagnosed disorder. So these kids appear at different professions. They can appear at physicians, or pediatricians, they can appear at speech and language therapists or at psychologists or psychiatrists. So we have to stick and work together to help these kids. Also, it is very important to gain a generalization of speaking behavior, that we all work together as different professions, but also with teamwork with others, like parents, like teachers, siblings, other related persons, to make this generalization happen, because it does not help if the kid speaks with me in my room. This is not the typical surrounding of a kid, but the aim of a successful treatment would be to speak, or for the kid to speak at its typical daily life. Yeah, and now I want to thank all children and parents that support our research, my colleagues and students. You might have seen these beautiful drawings. They come from a student of mine, which allowed me to show them here in the presentation. To Stephen Kurtz and Angelika Gensthaler, my colleagues. And of course, I would like to thank you for your attention. And I think we have quite a lot of time for questions.
Oh, Christina, thank you so much. You are perfect on the minute, on time. Thank you very much for this great overview and also for all your experience we see in your presentation. So I have really many questions also regarding the therapy, but most important are the questions of the attendees. So first of all, thank you again.
You're
So
very welcome. Thank you.
To give you a break, I will perhaps start with the first question from the question and answer box, but you can also raise your hands, dear attendees, if you have further questions. Okay. So one question it was the first one. Yeah, perhaps let's answer some technical questions. Yes, there will be a certification at the end of the webinar. There are some questions about that. And so there was also the question if we can have the slides afterwards. So these are formal aspects. Now I want to come to the content. So one question was if you have any opinion, or what is your opinion about the effects of age on mutism? Additionally, what is the key element of alleviating and worsening mutism?
Okay, the effect of age, does it mean, I suppose it means when typically we see kids with selective mutism. So selective mutism is a mental disorder that appears early in life. So typically, or the medium onset, age of onset is preschool. So between 2.5 and 5 years. This does not mean that we see these kids that early. And this is because the disorder is so little known and little diagnosed. So typically when it really causes problems is when the kid is at school, because then there are other demands, of teachers maybe, but still some of the kids only come to our departments when they are 15, 16, and that means that the time span when they had selective mutism is longer than the time when they were speaking without any problems. And this is the major issue that we face. So one advice would be to treat selective mutism immediately after diagnosis as early as possible. But the symptoms are there very early. And the other part of the question was,
what do you think, what is a key element for worsening or for alleviating or improving the symptomatology?
I think it's not so easy to answer this question because it's quite individual. So of course, if there's any teasing or something, this might worsen the symptomatology. On the other hand, I see many kids that are included very well in their class. There's not so much problem like this, but the other thing that I definitely see is putting pressure on the kid. Pressure about speaking is not helpful at all. So I would really refuse from that. Yeah. And alleviating, so I think if you are very child focused, if you take out the pressure of the kid. So what I typically say is during the first appointment, okay, I know you have difficulties with speaking with strangers, and I'm a stranger, I know, and so it's no problem at all if you do not speak with me today. It's totally fine. You can listen if you want to join in. I will be happy. If you don't, I don't mind. I will ask you to speak maybe to your parents here. Yeah, and this is because I don't want a contamination of my room as another room where the kid does not speak. But taking out this pressure might be very important. Yeah, and then these strategies that I told you that come from PCITSM, which I feel is really helpful.
Thank you, Christina. I try to summarize. It's really great to have so many questions. I try to summarize a little bit. There are questions also regarding the etiology. So what do you think about genetics? And on the other hand, there was a question about the influence of social media So both sides.
So definitely, like all other mental disorders, we do not have one single cause that causes the disorder. And also this is true for selective mutism. We definitely have biological influences. We do not have genetic studies so far, or not many that give us really good insight. What we know is that the rate of anxiety disorders in general, but also of selective mutism in families of a kid with selective mutism is much higher than in the general population, which is always a sign for some genetic influence, but also maybe for learning from parents. The other thing is that we also know is that a personality trait called behavioral inhibition, and this is something inborn, is much more frequent in kids with selective mutism and also in other anxiety disorders, but it's even more pronounced in kids with selective mutism compared to social anxiety disorder. And you can see that, like, if you have a small baby, then it crawls around, it takes everything in the mouth, it explores, and so on. And we have some kids that do that more and others that do that less. And we have some kids that are very shy, very anxious, that react with tantrums or with crying to some unfamiliar stimuli, to loud sounds. And these kids we call behaviorally inhibited. And this personality traits might result also, or might cause this over-arousal, this quick over-arousal, when confronted with a so-called or presumed threat. And this might lead to the freeze response, for instance. Yeah, social media, I'm not familiar with any studies about that. We know actually that kids with selective mutism, there's a latest study which just came out by the end of last year from the Netherlands, which nicely shows that kids with selective mutism use social media less than other kids with respect to, for example, words that they write on WhatsApp, Instagram, or something like that. So they communicate less, which does not need to mean that they consume it less, but they communicate less through social media as well.
Okay, thank you. So I go over the many questions. So another
I think you need to pick, Susanne.
Another package of questions is on the comorbidity. The one question was comorbidity with OCD, and another one was again with the developmental disorders. You mentioned that in talk, if it could be more a comorbidity or a separated diagnosis. So yeah, I will give over to you.
It can be, yeah, it can be both. So what we definitely see is more elimination disorders, but also more speech disorders in kids with selective mutism compared to typically developing children. So there's also that hypothesis of a delay of development, maybe, that is a cause, but it's not, it's just a hypothesis so far. With OCD, this is an interesting question. So what these kids, as I said, they have high behavioral inhibition. And one part of this behavioral inhibition is distress to novelty. So everything that is new is difficult for these kids. And this also, it's not like only new like social stimuli, but also other stuff like a new jumper. New trousers or something. And many people or many parents report that these kids refuse from using these stimuli, like dressing with a new trouser or trying new food. So these kids might also be oversensitive to new non-verbal or non-social stimuli as well. And so they appear very rigid. But for an obsessive compulsive disorder, we need more symptoms, like also a fear, for instance, or at least for the majority of obsessive compulsive disorders, a fear what can happen if I do not do this or that, or if I do not think this or that. And this fear is typically not associated with the rigidity that we see in many of the kids with SM. So I would decide whether I give a second diagnosis according to the full fulfillment of the diagnostic symptoms in ICD or DSM.
Mm-hmm. And yeah, there are then many questions regarding the therapy. So when I summarize, do you see any problems with the home treatment if the parents want to avoid that therapists come at home? What could be key issues for the schools? And a special question was also in the therapy in if you use also a recorder. Yeah, these are more practical points. So these are three questions: home treatment, school, and the recorder. And make a break here.
Okay, yeah, the treatment is, it's super exciting, I can tell you. Since I have learned this PCI-TSM with Stephen Kurtz, I'm very convinced of that. And I can tell that because it's not my idea or something like that, I just learned it. So home treatment is or might be very essential, and you're absolutely right. Some parents that are very shy or socially anxious themselves, they have difficulties with inviting somebody to their homes. So what I typically do is that I let the kid decide whether it's easier for it to speak with me in my department or at home. And some answer like this and some answer like that. So if the kid says no, it would be easier at home, then typically the parents can be convinced. Yeah. What is most important is go to the places where the kid remains silent. Yeah, this is not typically the home, but the school or the kindergarten. So we cannot just stay in our departments. We have to go to the places where the kid remains silent, or we have to teach the parents how to help the kid in these situations and make the parents go there. Also, of course, sometimes the parents cannot due to their own mental disorder, to language issues, whatever. And then I used to really try to invite teachers or kindergarten teachers and teach them PCI-TSM. So the more people you can include in this treatment, the better it is, because then we can target the symptomatology from all sides at all situations at once, and all with the same strategies. And I feel this is a very good thing to cover the quick generalization that happens with selective mutism. And the third part of the question was, Susanne, please help me.
The recorder, if you are using a recorder or recording.
Yeah, not many times. You can use it if the disorder is very severe, yeah, as a step in between. You should always make clear that it's only one step in between, like a bridge to help the kid speak directly. So the aim should always be that the kid speaks itself without a recorder. But sometimes it's helpful that the kid hears his or her own voice in a social setting before it speaks directly. So it might be helpful, for example, for school, if the kid records a presentation at home, and if the presentation there is being played at the school setting, and the kid and also the other kids hear the kid speaking. Yeah, this might be a bridge towards giving a presentation him or herself.
Mm-hmm. I now come to the other end of therapy. There are some questions regarding medication. The one was, when will you start? How long you would recommend to wait? And then it goes until non-response to SSRIs. A colleague asked if it's also recommended to use antipsychotics or valproate.
Mhm. So there you might need to help me, Susanne, as a
Yeah.
psychiatrist. We do not have any medication that is, it's all off-label that we do here. And I myself can only recommend. I'm not a psychiatrist. So what we see, and also what is recommended, is that in very, very severe and very, very chronic cases, SSRI is a good asset to the treatment. And there are some cases that I see for the very first time that typically have seen 2 or 3 other psychotherapists or speech and language therapists or whatsoever, or whomsoever, without any success. And I see the disorder. They are 16 years old. They have not spoken in public since they were 3. So it's highly chronic, and they have a very severe disorder. And this is sometimes an extreme form where I say I do not start the treatment without the kid being on SSRI. Because otherwise it is a negative experience again. What we see, but this is more clinical experience, I do not have any data for that typically the doses needs to be higher compared to depression. But in general, I see a very good response. It does not mean that the kid does not have SM just with medication anymore, but it's a good starting point, and it makes treatment or recovery for the kid easier. With antipsychotics, I do not have any experience. I don't know if you have, Susanne.
It is, I think, from the evidence side. So as you say, everything is off-label, but we have evidence for the SSRIs, and we have really low evidence for antipsychotics. So anyway, with the use of antipsychotics, I would recommend to be very careful, be on a very low level, as we are always doing if it's not a psychosis treatment, so very careful. So I think it depends more on comorbidity and not only on non-response. So yeah. So I think there is no clear and easy recommendation, and you should monitor that very carefully. And also with any other medication next to SSRIs, I think so. Yeah, and also as for other disorders, if you use the medication, I think we should always try to implement the combination with the psychotherapy and go not alone. This is really different from me in comparison to the adult psychiatry, that we think mostly if we use medication in combination therapy and not only in medication. I do not know what you think, Christina, but I think it's very important to try that.
Definitely. And it also depends on the disorder, of course, and about the protocol and the guidelines, of course. They do give recommendations, but I have not seen a single case of selective mutism that did not have selective mutism anymore after taking SSRI. So I would say it here, and with anxiety disorders in general, definitely this is a good asset, good co-treatment, but we still need some other treatment in addition.
Now there are some more case related questions. One case was a boy or a girl was not speaking in the family, but always outside since many, many years. What do you think about this? Yeah, about the treatment for such a case?
It's very rare. It's highly, highly unusual, I would say. So I would really try to do a good anamnesis, and really see if if there are any issues in the family context, which can be everything or anything, like mental disorders in the parents whatsoever. What we sometimes see, and here I would recommend to do the same if there's nothing like that. What we sometimes see, especially in older kids, that they speak kind of not fluently but easily with the psychotherapist, but once the parent comes in, they remain silent. So for them it's difficult to speak in front of the parents, and this in general applies to kids with selective mutism, that they sometimes have difficulty speaking in front of somebody who knows them only mute. Because this puts off obviously some pressure on them. So what we do here is a technique that is called sliding in. And typically I do that the other way around, but you can also do it in this situation. So the typical thing, if the kid does not speak with me, but with the parent sits with a kid on a table in my room, and they play a game where the kid needs to speak. And I sit with a chair outside of the room, but the door is a little bit open. And I explain to the kid very well before, and then I tell the kid, okay, I would like to come closer. Please tell me or show me how close I can come so that you remain speaking with your mom. And we open the door more and more, and I come closer. I sit in the room, but look away to the wall or outside the window. Then I come closer until I sit at the table with them and play with them, and the kid speaks with me. And then mom goes out slowly. So here, in this case, you can do it the other way around, like the kid sits with you and plays, and mom is sliding in, yeah, something like that. So, but definitely, since it's such a rare case and highly unusual, I would put a lot of emphasis on understanding the situation and understanding also the family system here, yeah, because I think I have rarely heard about a kid speaking fluently outside and not speaking at home. What we sometimes have is the kid speaking only to one family member, but not to the others anymore. Yeah.
Mm-hmm. Okay. Some other questions are you using also virtual reality and avatars? Mm-hmm. Or on the other hand, yeah.
It's very interesting. That's super interesting. I have never used it, and I don't know how to use it, to be honest. I'm not, but I find it super interesting. And there's one approach from Singapore that started with that. So we do not have much data on that yet, but there's something going on. And I would be really interested in seeing how well it works. And I can imagine that it's quite helpful. So it's already been done with other anxiety disorders. With super effects, yeah, why not? We just would need somebody who can program this kind of stuff, and I definitely cannot. It's not my superpower.
Yeah, yeah. I think very important for all these virtual things is the content. So yeah, the most important is the content, and that is what you offered us now. So it has to be the same within also the virtual application than in the direct therapy, I think. So some questions are regarding, is there a book where we can read what you have recommended, or for the PCIT for selective mutism?
Yeah, so this is definitely something that is difficult. There is no book yet. We are currently writing something which will be freely available, not as a book. We do not want to give it to any editor, but we will publish it, and it will be like a blended learning design for parents, teachers, but also for therapists, where we explain about selective mutism, where we explain about PCITSM. We have included texts, videos, quizzes in that, and I hope yeah, my aim is to finish it this week, but then my student needs to work on the programming. So I really hope that we can present it soon. So far, for all of those of you, and I suppose it's all because we are speaking English here, that need something meanwhile, I can highly recommend Stephen Kurtz's website. He has a lot of open source material there, and also a learning university, which is the basis for our book now. And you can freely take part in the learning university, which is kind of a course about PCI-TSM. Also, the SMA from the United States has a lot of materials freely available, and Stephen Kurtz does some training on PCI-TSM, which I took part in also, and I'm currently taking part in the training as a trainer. So by October, I will be able to also train others. And yeah, so this is some new development here, and also something also something I would like to mention for those that have kids or families with selective mutism. We are conducting a group therapy in Gießen this summer. During the summer break, it's about a 2-week intensive group treatment. It's like the Mighty Mouth Kids Camp in the United States that I also took part in. And for those that have kids with this disorder between the age of 5 and 9, that would be willing and able to come to Gießen for 2 weeks, which is the demand, please feel free to contact me. Yeah, so that we can talk about it.
Thank you. Christina, we are at the end. Thank you so much.
Yes, thank you so much for your interest. It was awesome. Yeah, thank you.
Yeah,
and thank you for helping me with all the questions.
Yeah, and to all participants, especially to you, Christina, to all participants, we are directly at the end. So Sue Wong has written to you that you can ask your questions to her, to her address. And yeah, thank you again. I want only to share at the end one slide with you. I hope it worked. Yeah, we see Christina again. Everything worked in between, but I want to mention the Congress in May in Rio of our society, and also the next webinar will be held in March, and the special date will be announced by Sue Wong in our office. And yes, at the end, I thank you very much for your attendance and for the great participation and your questions. And we hope to see you soon again in March or in May in Rio.
Thank you. Bye-bye.